Good afternoon, everyone, and welcome to ETHealthworld's webinar doing a deep dive into India's antimicrobial resistance crisis. I am Rashmi Mabiyan Kaur, your moderator for this important conversation. AMR is no longer a looming threat. It's here and it's killing thousands every week, often in silence. Once treatable infections are becoming deadly due to widespread misuse of antibiotics in humans and animal health. Today, we are bringing together an exceptional panel from public health, clinical practice, biotech innovation, and hospital operations. Our goal is to explore that this will take meaningful blend from the AMR curve, from surveillance to stewardship, from policy to patient care. Now, let me introduce our speakers. Dr. Raman Gangakhedkar, Distinguished Professor, Faculty of Medical and Health Sciences, Symbiosis International University, Pune. Dr. Taslimarif Saiyed, Director and CEO, Center for Cellular and Molecular Platforms. Dr. Tanu Singhal, Consultant Pediatrics and Infectious Diseases, Kokilaben, Dhirubhai, Ambani Hospital, Mumbai. Dr. Anita Arora, Director Medical Operations and Group Head Infectious Prevention and Control at Fortis Healthcare. And we will also be joined by Dr. Raman Lakshmi Narayan, Founder and President One Health Trust. And thank you so much to all the speakers for joining. The discussion for today will be followed by a question and answer session. So the attendees can share the questions in the chat window below. Thank you so much, speakers, and I would request you to please turn on your mics whenever you're speaking. So to start this discussion, I would like to begin the flow by actually understanding clinical front lines on when antibiotics fail. So my first question is for Dr. Tanu. What are some real-life cases that you've encountered when even last resort antibiotics fail? And how do you communicate this reality to the patients and families?
Thank you, Rashmi, for inviting me for sharing my experience in this webinar. One important point which I would like to make at the outset is that many of these patients who get these extremely drug resistant or pan drug resistant infections do not succumb just because of that infection. Often they have other comorbidities also which make them succumb. So, the attributable mortality is not just because of that infection. So they often die because of multiple causes, but that infection is one of the contributing factor. We often have these cases in neonates, children, and adults. So, one of the recent cases we had was of a liver transplant patient. This was a lady who had undergone a liver transplant, and she had been in our hospital for a long time because she had developed stricture in her bile ducts, and she had developed multiple infections, like she had developed a CMV infection, and then she had a indwelling line, and she had developed an enterococcus faecium infection, which was actually highly drug resistant. It was resistant to vancomycin, daptomycin, and linezolid. And the only drug to which it was susceptible was tigecycline, which is not a good drug for bacteremia. And we could not cure that infection. We gave her antibiotics for a long time, but because she had endocarditis also, so we could not cure her of that. And finally, what happens in some of these patients is that they become so sick and they run out of finances that she took discharge against medical advice, and she succumbed on way to her house. So some of these patients actually die in hospital. Some of these patients, they run out of money and they do dharma. So we see more deaths due to resistant gram-negative infections and sometimes due to gram-positive infections. And in some cases, we have drugs to treat these patients, but the drugs are very expensive. Like, for example, for Acinetobacter, which is one of the highly drug-resistant organisms, We had a patient who had a Acinetobacter pneumonia. And that patient, we were giving this drug, polymyxin B, for a long time, but his infection was not getting controlled. So we have this drug called cefiderocol, which is not available in India, but it has to be imported. So this was a very affluent patient. So we suggested that if you can buy it, through a party which imports the drug. They said, yes, we can do it. But the cost of treatment with that drug is like, 4 lakh rupees a day, which is out of, in the reach of any common man. But this family was able to fund that treatment, and we treated the infections successfully. But then the patient died of a myocardial infarction because he was in hospital for a very long time. So, what I just want to tell you is that sometimes we cannot treat the infection, and sometimes we have drugs to treat the infection, but these are not affordable by many patients. And sometimes you do treat the infection, and then it's too late, and the patient succumbs to something else.
Yes. While you did stress upon the fact of comorbidities, I would also like to come on AMR being witnessed in pediatric patients, and how has your practice of treating the pediatric infections, especially in neonatal, changed over time?
So they gone are the days, when you would be able to treat neonatal infections with ampicillin and gentamicin. That was there a long time ago. Now you have newborns who are infected with carbapenem resistant bugs. So you have to use drugs like colistin. You have to use drugs like ceftazidime, avibactam, aztreonam. And lately we had a newborn who was in an ICU in Kolkata who had Acinetobacter sepsis. We had to use this drug cefiderocol because there was just no other antibiotics that we could use. So, in fact, there was a study which was done in New Delhi in 2015 where they found that 50% of the pathogens were resistant to carbapenem. So, that is also the NeoORB study, which was a multicentric global study where they have found that Klebsiella and Acinetobacter are resistant to carbapenem. So that is actually a very serious thing. And you have Candida coming in newborn sepsis. So I think there is a big problem in newborns as well. So apart from adults, in newborns also we are seeing a lot of carbapenem resistant infections, which is making treatment of infections very difficult.
Okay, so I want to move to how actually the measures of prevention and control are being taken, Dr. Anita, to you. What are the biggest systemic gaps that you see in implementing these hospital-based antimicrobial stewardship programs, especially in India?
Thank you, Rashmi, and pleasure to join you all on this forum. So regarding systemic gaps for hospital antimicrobial stewardship, I think it varies in the sense that, and so let me start with a little background. I mean, we all know about antimicrobial stewardship in our country now. We talk about it a lot, but it started in the West. The guidance documents were prepared there. They were prepared according to those countries' needs. We currently don't have a central or a national antimicrobial stewardship guideline or document in the country. But accreditation in the country has made everybody create antimicrobial stewardship guidelines and documents. So those, at least, so let me, instead of talking, so if we talk about non-accredited hospitals or other hospitals, smaller hospitals, then there is nothing in place. And so everything is a gap. But if we talk about even the accredited hospitals which are there, and they have created their documents to have, that I want to know how to use my antibiotics. I've created my antibiotic policy. I have created a policy for prophylaxis, which I need to give for surgical patients, for treatment for other patients, etc. Yet we find that there are gaps which would be, across certain hospitals. There may be few, and they may not be there today. but they may come up again over a period of time. So these gaps range from, starting with the manpower. So the Western documents describe that we need to have an ID physician, we need to have clinical pharmacists. These two categories of manpower are definitely very few in the country, very few even in the private hospitals or even the accredited hospitals. And so the Indian guidelines or the hospitals have made guidelines to try and, circumvent this by using clinical microbiologists or clinical pharmacists, if they could train them, or even the clinical pharmacists, if they could, work with them. Another gap, which is besides the manpower availability, is even microbiology labs, having a laboratory which is capable of, which is equipped to be able to, do all the tests and do it whether in a manual way or using automated systems or even the newer systems which are there. That provision is not there across in many hospitals. And then, of course, there is this gap of the clinicians not wanting to send cultures to the microbiology lab, even if there is a lab, because they feel it takes time or they don't have faith in the report because the positivity is not so high. And so that's a known fact that the positivity will be there. And then coming to even if you have a good microbiology lab, which gives you a nice antibiogram, which is that tells you which antibiotic will work, which antibiotic won't work, and the hospital creates its antibiotic policy. Even if they create it, do they use it? That's a big gap. Do they rely on it? Or does the clinician think I have some antibiotic in my head and I will use it? So those gaps remain. And of course, the gaps of cost, which Dr. Tanu was talking about, also exist. So it varies, as I said, from hospital to hospital, accredited or not accredited. And then finally, are we working enough to, do enough capacity building about their skills, their knowledge, and of course, providing them all the resources, even if I have the capability, the financial capability to provide it. So those gaps, so these are some of the gaps which exist. Today, a hospital, and this is not that, today I don't have it across the hospital. It may start with that I have it today, but along the way, I just decide that, okay, you don't need this, or this is not required, or this is not cost effective. So we stop providing those resources. And so then starts also the other challenges which come across with that. So I think that's in brief what I wanted to just share over here.
And do you think Indian hospitals are adequately equipped in terms of surveillance and containment if at all there is an MDR outbreak?
So, COVID was one example which told us, whether an outbreak happens, what can be done, cannot be done. But let me say that most hospitals, and especially the accredited hospitals, definitely have adequate manpower, adequate resources to handle the MDR outbreaks. Even most public hospitals, even if they are not accredited, would have them, especially the larger hospitals. That saying that, it's very difficult to comment about what smaller hospitals would have in the country, whether accredited, whether not accredited, and whether they are rural or urban. So, but broadly, I think if you talk about the larger hospitals, everyone's well equipped, whether it's related to the staff, having qualified staff. Of course, there's attrition, so that becomes a challenge. And then replenishing the staff with adequate numbers. But do we have adequate doctors, adequate nurses for one-to-one patient, and the other paramedic staff which we would need for managing an MDR patient? That is there. But more importantly, or I should say parallelly, it is the resources. Do I have for an MDR patient or an MDR outbreak enough rooms where I could put them? Or is there a way, so I do have adequate number of isolation rooms, depending upon whichever type of precautions I would need. There are various types of contact, airborne and droplet, depending upon what's the route of transmission. Or do I have provision for cohorting such patients? Like, can I take one large ICU if I have an outbreak and I have multiple patients? Do I have it? So those provisions need to be, so they need to juggle their resources at times. Large hospitals can do that. and they have it in place, especially if they are accredited. They have adequate nursing staff who would take care of such patients one-on-one. They have competent, qualified staff. They address their attrition in various ways. And then coming to the surveillance of such patients, for this surveillance of MDR, you have the infection prevention and control nurses and the linked nurses which are there. So all that is definitely in place, and they have their adequate numbers and the place because they do it for accreditation. Well, we won't discuss that. They may at times just do it for an upcoming assessment, but good hospitals have it throughout the year, have it throughout over the period. They're very disciplined. They address their challenges, and so that they keep their infection prevention control measures in place for whether it's MDR or any other kind of infections which they need to do it for. You are on mute, Rashmi.
Sorry. Yeah, so my next question is for Dr. Raman. India's National Action Plan on AMR is approaching a decade since the launch. In your view, what have been the most impactful public health measures so far, and where have we fallen short, according to you?
That's a very tough question. Now, if you ask me, the moment you say it's almost 10 years old, have we made a major difference? Perhaps not. We have not yet been able to even start surveillance system well, whether it comes to education of the clinicians, whether it comes to trying to make the community aware. Those kinds of steps are still in a primitive stage to my mind. Now, to call it as what has been successful, the only thing we have probably managed well is we at least have a national AMR policy in place. No? Now, to ensure that the implementation improves, ensure that adequate steps are taken, perhaps is something which we will have to think about in the near future at this point in time. We also need to understand, we understand that these are issues which need to be addressed quickly. But at the same time, we also have to understand that you have 2030 goals for other infectious diseases which need to be eliminated. And the entire focus tends to go there because those are all having vertical programs. Whereas for AMR, one of the major gaps is there is no vertical program. And unless you have a vertical focus program, it becomes very difficult to ensure that the adequate steps are taken and monitored as well. No?
Yeah.
But to me, more than successes, we have lot of things that we will have to do in near future. That's a reality which I can't do anything about.
And since the AMR surveillance is still fragmented, if you could tell us some nationwide surveillance system examples, or what are the measures that can be taken?
See, the first AMR surveillance was started by ICMR. No? There were about 20 odd hospitals until now, which were private tertiary care hospitals largely. Did it have a kind of a generalizable framework, based on which we could come out with some findings which could be generalized? No. These are those hospitals which had infrastructure, willingness of the clinicians, microbiologists to work along, and largely they were based in the cities. Of late, Raman's group is also working. They are also trying to develop a network where such activities could be performed. There is another one in Kerala, which NCDC tends to operate, which is largely statewide cover that they have been able to produce. Now, these efforts have been made, but they have been fragmented. And the reason why they remain fragmented is the infrastructure continues to be a challenge. No, when you want to do a surveillance, you should not aim at something which is highly sophisticated. You have a tertiary care center, you have secondary level hospitals and primary health care centers. Now, if you want to do surveillance, surveillance has to be done across because action cannot only come through tertiary care centers at that juncture because the prevention has to occur from the primary and secondary levels per se. Now, in order to do that, you need to have monitoring indicators which you can use at those levels, which may be a little crude, but their willingness, their ability to access different tests continues to be a challenge. So essentially, it means that now there is some impetus, at least in tertiary care hospitals, including medical colleges today, are little better. It's not only the private medical colleges or private large hospitals, but things have been moving. But that movement that is occurring in urban areas is largely because you have corporate sector which has taken over and the quality is being maintained by corporate sector. But when it comes to government sector, I think we have a lot of efforts to be put in before things can happen. Even now, if you were to look at initiating some kind of surveillance effort, perhaps this will only be restricted to the tertiary care hospitals. But if you ask me, I think you have to do it at all levels, including community, if you want to understand and mitigate this issue.
Okay. So but I'll come back to you because that's kind of a question that we'll take to all the speakers. My next question is for Dr. Taslim. Since we are now going to be talking on the biotech opportunity that we see here and how innovation and diagnostics can actually play a role. So how do you think India's biotech startups and academics labs play more of a central role in developing point of care AMR detection tools?
Yeah, no, it's great to be here. Thanks for the invite. I think,
So your audio is not very clear.
can you hear me? Hello?
It's very feeble. If you could try without
Can
the
you hear me?
earphones, maybe we
Is
can
it
try
better?
without the earphones.
Is it better?
Yes, I think we'll go on. So if there
Okay,
is an issue,
okay. I'll try to continue. Sorry about it. So, no, I think you are absolutely right. I think there is a significant requirement for us to equip our healthcare system with new solutions which can enable them to do an quick, affordable way of diagnostics and even therapy. Very, very important. And I think it is very important considering we all know the larger burden of AMR that India has. It's very significant. And we also know at the same time that while conventionally we have been able to bring in the global solutions and bring into India for many of those remain in very few setups. It cannot be in every setup because of the expenditure that is built around it, the costs which are around it, which are not available, and also accessibility requires a certain environment, the capability, skill, and so on. They are largely built in for the environments which are different from it. A. B. They are also built many times for different patterns of resistance which are there compared to what we see here. So definitely, there is a significant need for us to go on and understand our own needs, understand the dynamics of our own needs in the AMR setting, and then try to build those solutions which can come and equip the healthcare settings, healthcare professionals across the value chain of healthcare per se. And that's where the role of both the academics as well as the startups and industry becomes very, very central to it to ensure that we can do that. And there's a lot of effort that is going on in that direction. And something if I may bring in under the guidance of the Office of Principal Scientific Advisor, a couple of years back, we have set up what we call it as an India AMR Innovation Hub, which is in a way becoming a national effort to continuously enable new solutions, new science and technology-based solutions across in prevention, diagnostic, therapeutic, against the prioritized problems or prioritized AMR problems of it. And that is very, very important. It's a very mission mode effort that we are trying to do at CCAM under the guidance of the Office of Pediatrics. And this actually is weaving in to the larger effort that the government of India is doing, and building towards NAP 2.0. As you rightly mentioned, that is something that is needs to be kind of revised. It has been working on, and I think any day or any week now, we will have an NAP 2.0 for India be released very, very soon. And there you will see that a lot of ministry-wise deliverables and accountability will be built in. So IAIS, India AMR Innovation Hub, will be driving the innovation efforts, which will bring in attempts for early detection, be it for neonatal sepsis, specific ID for pathogen ID, be it resistant patterns or the AST as you call it, also the therapeutics. We have a few efforts going on in therapeutics, small molecule based effort we have a peptide based effort going on. They are in the clinical trials already. We have some efforts in map based work. So these are really very good work, and the therapeutics one are already significantly seen at the global level as a very good work that is going out. So collectively, academics and industry and startups have a significant role to play in bringing those solutions out, including in prevention, which I didn't mention much, but also how do you prevent those components by doing that, and also building, affordable, accessible solutions which are there. And we have now, at least within IAIS, we have now been able to begin the work, and at different stages of development, nearly 80 of such innovations are being built. So that is very important, good progress that has been made. And we are working with different government as well as state governments now to ensure that as they come to the level of deployment, how do we validate them in different hospitals? How do we then actually get deployed to different state governments as they prepare to? So that's a very important thing. What we hope, and if I may conclude on this point right now, within 5 years, we are hoping to bring in AMR-based solutions for India, largely at least 15 to 20 in the field by the end of the NAP 2.0. That's the target that we are setting for ourselves, and we have built both national and global partnership to be able to deliver. I'll stop here, but happy to take detailed questions.
That is very interesting news that you've given here. The second part of the question, because we touched upon AMR, and a lot of it actually comes again on the financing part of it, the cost that becomes a barrier. So do you believe that in incentivizing antimicrobial development and diagnostics through public-private partnerships could help bend this curve a bit?
Absolutely. I think without a doubt. And I think we need to consciously do that, because I think public-private partnerships are must when there is no a kind of a conventional process goes through, right? When in conventional process, there is science being done, there is a market for science, the science moves forward, industry takes the science, looks at the big market, builds the solutions and takes it forward. In infectious diseases or AMR, the market in a way is very, very fragmented and is not pulled in a pull. And hence you need public, that is government, to be still playing a stronger role and not stay very early stage and come and partner with industry. I think it's a very important aspect that we need to do it, not because only we want to support industry, but we want to ensure that industry has enough support to bring solutions out. Otherwise, the entire pipeline, including for therapeutics, will be broken if we don't provide the structure and not ad hoc support, but structures for them to actually build. And the examples are very clear. I think globally, it is a fact that the market is very difficult for the therapeutic companies to take their molecules forward. And hence, we need very structured public-private partnerships where there is a support from government, there is a support from industry, foundations can come in, and different models in pull incentives and many other things are built to so that it can be put in. And we have those examples in many other countries already, including in the UK. There's a guaranteed pull incentive they have been able to do that anybody who actually bring a therapeutic molecule out regardless of the use, there is a contract for 10 million pounds, which is being built in. Now, that's a guarantee that anybody who is successful enough, regardless of the usage of it, you have a guarantee, because that is what you call the prepared. When you have MDR things, you have many other things. You need, as a nation, to be prepared so that you have, what we didn't have in COVID, you need to have in such scenario. So we can access it. And for that to have it, you will have governments have to play a bit more, significantly more, or rather more involved role compared to the conventional process of healthcare solution, which has a strong market, be it oncology or many other things. And that's where I think that is the only way we can ensure that we can bend the curve in terms of good diagnostics to prevent AMR or appropriate treatment, and then therapeutics to ensure that there is good solutions for a variety of resistant patterns that we have seen.
Okay, thank you, Dr. Taslim. So, coming back to Dr. Raman, sepsis caused by MDR organisms is now among India's top infectious killers. And why do you think it hasn't triggered a public health emergency response till now?
There are multiple reasons. No? If you think about it, when you don't have a generalizable data on what is the impact of AMR and why this sepsis is occurring, you will find it difficult to advocate. No? The result is, if you look at one of the major issues with AMR, is we tend to have only headlines in newspapers. But does the community demand it? No. Would the hospitals take over that particular issue and try to bring it to the fore? Perhaps not. Now, if at both the ends things don't happen, every single death that tends to occur will be an anecdote for people to quote. If you want to have good numbers, you need to have good surveillance system in place where people keep on demanding for those services. Perhaps these would be still possible. If you ask me, though people were quoting about COVID, one of the things which we have missed, that we did not build the case after COVID epidemic, the serious part of COVID epidemic was gone. No? We could have used that opportunity to build on different issues. One of the things which we built, at least today, is ensure that there are ID blocks in the districts. We infectious disease blocks have now mandated in the district hospitals. Ventilators are available. And then perhaps RT-PCR machines are at least available at every district level. But have we built on that infrastructure which we currently have? Perhaps not. We could have utilized those opportunities well. We did not pursue that part to advocate with the government. So we have to understand that if others do not take up the issue, each death that occurs is just an incident. And it is up to us as to how we will take the whole thing forward. One of the challenges is, you can't have a community advocacy as you have in TB, HIV, leprosy, because these patients can come together. When it comes to death due to sepsis, people are at loss. Who should I talk to? What is going to be my group? No? And those issues are far more challenging to my mind. So it is up to us and the community. We have to educate the community. We have to ensure that community demands that somebody has to get certain things done in an appropriate manner. Only then things will improve.
Thank you, Dr. Raman. So, Dr. Tanu, as Dr. Raman touched upon educating the community and the people, we need to talk about the irrational over-the-counter antibiotic use, which is actually rampant in India. It was also seen during COVID. So, what kind of behavior change campaigns or guidelines do we need urgently, according to you?
So I think there is need, for these changes to occur at all levels. Like there are multiple stakeholders which are involved in this issue of AMR. So there is the government, then there is the pharmaceutical industry, then there is the healthcare organization, including the physicians, and then there is society. So, so the society also is responsible because there are so many people who pop antibiotics on their own. I mean, we have so many patients who come to us and say that I was having fever and I started azithromycin. They say my fever because they have heard about it, or they were given azithromycin or an antibiotic when they had fever, and that is how they take it, or they just go to the pharmacist and take it. So we need a campaign telling them that antibiotics should not be misused. So like we used to have campaigns, like for tuberculosis, that if you have khasi which lasts for more than 2 weeks, you should think it is TB. Or for polio immunization, there was a campaign. I think there should be a campaign in the media telling people that they should not misuse antibiotics. So that could be one kind of campaign which is directed towards the society, which says that people should not be taking antibiotics irrationally. Okay, so that would be on one side. Now, the second kind of education is for the physicians, because there are physicians all over who are prescribing antibiotics for viral infections. And that is happening because all over there are CMEs, and I'm part of multiple guidelines, etc., which and seminars and webinars which are being held, educating doctors that please do not give antibiotics for viral infections. But despite doctors attending these webinars, still this happens. So that behavior change needs to happen, that antibiotics are not given for viral infections. And if you look at studies, 70% of outpatient visits are due to viral infections, and if we cut down antibiotic use for these infections, you will bring down antibiotic consumption. So there also you can cut down antibiotic use. Then pharmacists selling antibiotics, that is something which needs to be addressed immediately. So now we have these laws that you cannot dispense anti-TB drugs without a prescription. So Kerala has done it. Kerala, there is a guideline now that the pharmacies cannot sell antibiotics without a doctor's prescription. So that is something which needs to come in the whole country, that there has to be a law that antibiotics cannot be dispensed without a prescription. So that should come in immediately. And that will also really, reduce the problem of antimicrobial resistance. Then antibiotic use in animals. I think recently there was, I think, a diktat when the government, said some groups of antibiotics should not be used in animal feeds. So, and I think Dr. Raman join because he's a proponent of One Health. So, antibiotic use in animals also contributes to antimicrobial resistance. So, the government needs to bring in laws like this, because their laws can really help quickly. Like, for example, the law of reducing, and prescriptions needed for antimicrobial dispensing by the pharmacy, and also reducing antibiotic use in the veterinary industry. These are some things which will help in, and also to ban irrational fixed dose combinations, and also to overall improve the quality of antibiotics which are dispensed. Because remember, when we talk about antimicrobial stewardship, we are talking about not only irrational use of antibiotics, but also we are talking about using the right antibiotic for the right patient to ensure the right outcomes. Because of this problem of, poor quality of antibiotics, etc., we are sometimes seeing poor outcomes in patients. So that is also which we want to prevent. We want to ensure that the quality of antibiotic is good so that patients achieve good outcomes. So that is also an important, thing that we have to ensure. So as I said, that all stakeholders have to do this. And Another thing which is contributing to the problem of antimicrobial resistance is that India has antimicrobial resistance because it has a high burden of infectious disease, which in turn leads to excess antimicrobial use. So, if we reduce the burden of infectious disease in the country, we will automatically reduce the consumption of antibiotics. And the ways to reduce the burden of infectious disease in the country is to look at, proper hygiene and sanitation, proper water supply, and to promote vaccination, because that will reduce the burden of infectious disease, like to bring in typhoid vaccination, which will reduce the burden of typhoid and in turn reduce antimicrobial resistance. So those are some of the long-term strategies that we need to look into to reduce antimicrobial resistance, because if you reduce the burden of infectious disease, you will automatically reduce the antimicrobial use.
Thank you, Dr. Tanu. Very beautifully explained the very key parameters. I'm coming to the last question of this webinar. As Dr. Tanu said, if we reduce the infections, ultimately we would not actually go for more antibiotics as well. So, Dr. Anita, the last question for you. Infection prevention and control often receives very less attention as compared to the treatment. How can IPC be made a central pillar in India's AMR response?
Right. Well, it's easier said than done. Infection prevention and control is a well-known, established system which is there. But do we want to do it or not is where I think the problem starts. So if I want to do infection prevention and control, I can do it. And as I was referring earlier to, accreditation has helped. So infection prevention and control is there in all these hospitals. They know they have to do it, so they do it. It is the other hospitals where it is the challenge. There's a beautiful national guideline on infection prevention and control, which is there. Those documents exist, from the NCDC. But do we want to do it? So the moment I want to do it, I will be able to do it. So for that, I will provide. So let me start with the hospital. I will definitely provide everything which is required, starting from the manpower, the other resources. We talked about some of the resources earlier, whether it could be, personal protective equipment, it could be rooms, which I said, it could be spacing between rooms, it could be the other supportive, departments like the sterilization department, the other supportive staff like the housekeeping staff, besides, of course, the doctors, nurses, and, the others. And so depending upon the area within the hospital, I could have this whole system in place, but the moment I want to do it, we can have it. So I would suggest that, we want to do it at a hospital level. I think the country level needs to mandate it, and they need to implement it across all public hospitals because they have a control on the public hospitals. The private and the corporate have their own systems, so they can do it. And that way, then the entire country would be covered. I mean, no, health is a state subject, so it becomes difficult. But I mean, I think certain things need to be taken up from the center. I mean, biomedical waste, that's the only gazette notification we have in the country, right? Which is a mandated requirement on how to manage biomedical waste. But we could have certain other central mandated requirements, which we could start small. I mean, as Dr. Raman was mentioning, that customize it for the smaller. Start with, a primary healthcare center, a district level, what can they do? And then build on it. I mean, let's start with that. So I think that's the way to go about it. And I'll stop here. Thank you.
Thank you, Dr. Anita. And thank you all the experts. We will now take some audience questions. We have a couple of minutes. So these audience questions are open to everyone, and anyone can choose to answer or give an input in any of the questions. So the first question is, when you're talking about One Health approach to AMR, how well is India integrating human, animal, and environmental health in its AMR response? And what do you think a stronger alignment would look like if in practice? Dr. Gangakhedkar, would you like to take it?
I know. No, there are some harsh realities, no? When you have One Health, you have so many departments, almost 5 to 6 government departments have to work together. Now, if you want to make them work together, coordination becomes a very big issue. And each of them have different level of maturity. No, so interacting with them, you will find in some place, "Acha, this fellow doesn't understand what I'm talking about." So essentially, if you have to do it, you have to have AMR as a line ministry item, no, within the Ministry of Health. No, you should have a department for antimicrobial resistance, which is given some kind of authority to reduce the coordination issues. And to be honest, no, it is possible that I had tried all that during my tenure in ICMR. One thing which I can tell you that perhaps veterinary department is far advanced. No, it is almost equal to human health related workers. We could align well, we could coordinate well, but it is going to require some amount of effort. And this, I think, the government is also currently aware of One Health issues. They are making their own efforts. But as I said, the challenges are related to multidisciplinary approach that we may have to adopt here.
Okay. Okay, so moving on to the next question. India is one of the highest consumers of antibiotics globally. From a policy and economic standpoint, what regulatory or pricing interventions could effectively curb antibiotic overuse in humans and veterinary sectors?
But that part, I think I can take.
We've covered a bit of it,
Maybe.
yes. So
No,
maybe
it is
regulatory and pricing, if someone would like to comment.
Yeah, there is something which is called as essential list of medicines where you can control the costs. No, the drugs that you want people to have access to, you will perhaps control the cost. And for antibiotics, perhaps you may not cover them as much, which you want to actually retain. Second way is you have to approach CDSCO, and CDSCO comes out with legal provisions. But all of us must also remember that prescriptive options, where laws tend to come, they are good for short term. If you want to make a difference, people develop their strategies how to overcome whatever is legally mandated. So what we need to essentially do is raise the awareness. And if I was to give one simple answer in one line, what can make a difference? If we ensure that every patient who walks in for any consultation asks the doctor, is there an antibiotic in it? You will find that it will create a huge demand to be rational in one's own prescriptions.
Okay. So, I'll move to the next question. What are the economic costs of inaction on AMR in India, and how can better data or AMR economic burden drive political will and investment in containment efforts? Anyone would like to take that question?
I can quickly do it, and I'm sure other panel have better idea. I think there is a need to actually understand the economic impact of our inaction, possibly, or slower action to do it, which is definitely impact on health, loss of lives, even other things. But I think such a detailed assessment which is required, I think, has to be done soon enough, according to me. We do not have that data, latest data available for sure, and something that in a way is being discussed but hasn't been implemented. But some countries have done it. Some countries have done it even for every year of the work globally, people have done it in those countries, and they have been able to show over year what is the economic cost that would happen, and including the Delhi as one does the economic impact. But we do not have those numbers, at least as far as I
No, we have actually one of the papers which we have recently published where we show that AMR, what kind of incremental cost you would require for the same and why that becomes important. But the reality is there is a big challenge. If you look at it from policymakers' point of view, you have a public-private partnership model in healthcare service delivery. So essentially, those who can afford, they go into private sector. Those who cannot, they continue to remain in public sector. And therefore, doing economic calculations becomes as difficult, as to what kind of saving I would have, because there is public-private partnership here. But the issues are very clear. There is a constant effort from ICMR side as well to try and look at the cost-benefit angles, related to AMR.
Okay, so we will now go to the closing session. There is one question, and I would request all speakers to give their brief answer. And I would like to start with Dr. Tanu. So, if there is one bold policy change that you would like to implement today to slow the AMR crisis, what would it be and why? Quick 1 minute answer.
Yeah, so I feel that stopping over-the-counter sale of antibiotics would be that one big policy change which I think should come, to slow down the process, AMR. I think that is urgently needed. Thank you.
Dr. Anita, your views.
So I think, if you want, I think we have a lot of irrational antimicrobial combinations manufactured in the country. And they continue to be manufactured and approved by respective states and get circulated throughout the country, right? I think we should just not allow, or we should not, I don't know if you can stop manufacturing. The moment you have a deterrent that I'm not going to approve it in a state, so then all states should be empowered that, and it should go through the CDSCO or whoever else it needs to go through. But I think no irrational antimicrobial combination should ever be circulating in the country. There are innumerable ones. We are aware, and we do not, at least in our hospitals, allow them to be used for our inpatients at all. We cannot control what somebody prescribes outside the hospital, but definitely that's one thing I think I feel very, I have many more, but I think this one is good for now. Right. Thank you.
Dr. Raman, your views.
Wrong person to be asked. If there was only one thing that could make so much of difference, we would have definitely made it. But it is unfortunate that it is multifactorial. One of the things still, what I would say can make a difference is we need to have coordinated efforts coming. And those efforts, you cannot say that the veterinary should be left alone or poultry farms should be left alone. It is a multifactorial disease. And if you want that to actually do well, to me, community's level of awareness, community asking questions on each death, that tends to occur is perhaps important. So to me, every person who walks out of the clinic, if he asks questions, whether I have received an antibiotic will make a difference. Every death that occurs, is this attributable to AMR? Perhaps some kind of material for advocacy would be generated, because here action cannot come only from the government. The action there are so many stakeholders in the whole thing. You cannot talk about only one step at this point in time, at least.
Thank you. Dr. Taslim.
No, I completely agree with them. It's definitely a multifactorial thing. But if one thing that we have to go after, and we are only allowed to do one thing, it would be going after appropriate use of antibiotics across all health. Because we do all know that there's a significant usage in non-human environments as well, including aqua, including agri, and even other usage patterns. I think appropriate use, understanding, and is very, very important, and implementation. While there is an intention, while there are policies, how do we actually get to the implementation and achieve
Yes.
that would be something that would be very important. It will have one of the biggest impact, while other things will have to continue.
Now, if I can add one more, I take the liberty. What is most important to my mind is provide funds for development of low-cost point-of-care test, which will distinguish between viral and bacterial infections, and they could be made available across all strata, primary health centers to everywhere, wherever we can talk of. Perhaps that will restrict the use of antibiotics very quickly. But we have to take it on as a head-on mission to develop one.
I second that. Absolutely.
Thank you. Thank you so much to all the experts for such a beautiful, powerful discussion and the insightful reflections that we've heard today. So, what we've heard today about the need for better surveillance, behavior change, innovation, ecosystems, stewardship enforcement, and stronger One Health alignment. But above all, the urgency is clear. AMR is not waiting for us to catch up. We need coordinated actions across sectors and systems before the age of antibiotics truly ends. Thank you for all the panelists for joining us, for their time and expertise, and the audience for joining us and staying connected. Let's continue to raise an awareness, demand accountability, and drive solutions. Thank you so much, and have a great day.